Good evening, everybody. Welcome you to the 12th session of the Ishks teaching program. And today we have an interesting session. We have two good topics. So on behalf of the Ishks committee, the trustees and Dr. Vikram Shah, President Dr. Indrajit Sardar, Secretary Dr. Leo, and Education Committee, myself and Dr. Dipak Dave, we welcome you all to
Recording in progress.
Teaching program. So we have two excellent speakers and two interesting topics. First is topic by Dr. Anoop Jhurani. He's going to talk about the difference between mechanical and kinematic alignment and which to do. And he's a well-known speaker, doesn't require an introduction. He was the part of Ishks Executive Committee and was the IAA president. He's a senior consultant at Jaipur and doing joint replacement surgeries, and he has multiple publications and published a textbook also. So to start the program, I welcome Anoop to share his screen and start the presentation. Thank you, Anoop and Anil, for sparing your valuable time and being with us to teach our students and the fellow society members. Thank you very much.
So thank you, Dr. Pachore, Ishks, Dhanasekara, Dr. Dave, and everybody involved in this program. So can you hear me?
Yes, Anoop.
All right. So since this program is for FNB students and the younger crowd as well, I'll start with some basics and highlight the difference between mechanical alignment and kinematic alignment and why we are questioning mechanical alignment in spite of its success for last 2 decades. So there are certain valid reasons. And the first reason is, to my mind, why I started thinking about kinematic alignment and started looking at the evidence long term is because we release a lot of soft tissues in mechanical alignment. And these soft tissues are responsible for normal feel, form, and function of the knee. And kinematic alignment, the beauty of kinematic alignment was to maintain the length and the laxity of the ligaments without going beyond the midline, without releasing or pie crusting the MCL, preserving the posterior cruciate ligament and the retinacular ligaments. Once I realized how important this was for the normal feel of the knee and normal recovery of the knee after knee replacement, I started thinking about it, working on it, and reading the literature and investigating on my own. So we did mechanical alignment for almost 13-14 years, from 2007-8, and then from 2010 to 2021 through navigation, and following Dr. Ranawat's principle to the T, cutting the femur at 0 degree to the mechanical axis, cutting the tibia at 0 degree to the mechanical axis, and aiming for a neutral hip-knee axis. Dr. Dave, there is some disturbance from your side, I think. No. Yeah, that's okay. Yeah, thank you. So, aiming for a neutral hip-knee ankle axis. Now, while we were achieving great full-length X-rays and great X-rays, the patient still had 2 problems that remain in my hands, in my surgical hands at least. One was stiffness in some patients. The reason was that when we were releasing, we were sometimes over-releasing and causing medial opening, and then putting a 11 poly instead of a 9 poly and giving stiff knees. So that was one problem that remained in my hands. And second thing was instability. The reason was that while cutting, even with navigation, you could easily cut 1 or 2 millimeters more through a jig and create instability either in extension or in flexion. So these are 2 problems that remained pertinent in my hands at least. That was stiffness and instability, and that is the time that I started looking at kinematic alignment very seriously and started following all the principles. But first things first, so the green line in the next few slides is the mechanical, and the red lines are, or the red line diagram is for kinematic. So in mechanical alignment, as you all know, it's a coronal plane alignment principle. So we don't discuss much about the sagittal plane in mechanical alignment. Mechanical alignment basically is cutting the femur and tibia perpendicular to the mechanical axis and then releasing the soft tissues to obtain a straight HKA. That's the basic principle or premise of mechanical alignment, and it's confined to the coronal plane primarily. It does not talk of the sagittal plane or the axial plane. It does talk of 3-degree external rotation because you're cutting the tibia at 0 degrees. But beyond that, there is no concept of how to recreate the knee joint kinematics, which kinematic alignment so does beautifully by replacing the knee in such a manner or resurfacing the knee in such a manner so as to reproduce the normal femur valgus joint line and the tibia varus joint line and not releasing any ligaments. So that is the first and most important principle of kinematic alignment. Here you see again the green line is mechanical alignment, the red line is kinematic alignment. So the green line, you can see that we are cutting perpendicular to the mechanical axis. And you never know when you're putting your intramedullary rod whether you're truly perpendicular to the mechanical axis because the femur may still have a bow. So you really don't know what you're doing. And with conventional techniques, it's absolutely difficult to cut at 90 degrees even if you're aiming to. While in kinematic alignment, you measure the cuts. So what you do is, even if you're doing conventional, you measure the lateral and the medial cut, account for the cartilage loss and the saw curve, and cut equal distal lateral and distal medial, that is 8 millimeters from the lateral and 6 millimeters from the medial. Add to that 2 millimeter of cartilage loss and 1 millimeter of saw curve, that's 9 millimeters. So basically you measure everything meticulously, even if you are doing conventional technique, so that you are cutting equal distal lateral and distal medial. Right. Now let's come to the tibia. Again, the green line is the mechanical alignment, which is perpendicular to the mechanical axis. And the red line is kinematic alignment, which is retaining the normal varus on the tibia, which is normally 3 to 5 degrees. So you can start with 3, go up to 4, and very seldom you'll need to go beyond 5 degrees. But basically you cut equal from the tibial spine, lateral and medial, mostly 8 millimeters. And not like mechanical alignment, you will cut 8 and 0 or 1 millimeter from the medial side because you're aiming for perpendicular to the mechanical axis. Here you want to reproduce the normal varus of the tibial joint line by cutting equal from the tibial spine. So you cut 8 and 8 millimeters from the tibial spine. I'll just describe that in more detail. Now here are 2 full-length X-rays. And as you can see, if you really analyze the full-length X-rays properly, all our femur and tibia are differently aligned. And it's very difficult to get 90-90 in mechanical alignment. Even if you're hardcore mechanical alignment guy, it's very difficult to recreate perpendicular mechanical axis. Now, what you do exactly, if you see here, if you cut perpendicular to the mechanical axis, you're creating a trapezoidal gap. The gap is not actually trapezoidal. We are creating it. It's iatrogenic. And all the medial tightness is not there in the knee, but it's created by us by cutting perpendicular to the mechanical axis and then doing all the medial release. So mechanical alignment is a concept that needs to be changed and challenged now, because the soft tissue releases actually are not required but are created because of our cuts. So once we cut perpendicular to the mechanical axis, we create tightness on the medial side and then we do soft tissue release to balance our knee, which can create instability patterns. Now, I talked about the coronal plane. So mechanical alignment, as I said, is purely a coronal alignment concept. And it does not say anything about the sagittal plane, especially on the femur side. So kinematic alignment speaks a lot about maintaining the flexion of the femur component, that is between 3 to 5 degrees. While in mechanical alignment concept, you can give up to 7-8 degrees flexion, not know about it, not think about it, and not feel the implications of giving increased flexion, which is very easy. with conventional jigs and instruments to give more flexion, and that causes proximalization of trochlea and patellofemoral impingement issues. So it's very important to look at the flexion of the femoral component. Now, to highlight this, I'd like to share with you this video. Now, this is a robotic screen video, but you can understand what the implications of flexion of the femoral component are. So just see that we are increasing the flexion of the femoral component, and please look at what is happening at the posterior cut. So you can see that when you give 5-degree flexion, the cut decreases by 3 millimeters. That's the nature of importance of flexion of the femur component. Now you can see at 0-degree flexion, it was 11 millimeter cut. I'll just play that again. Yeah, please mute your screen, Dr. Sardar. Please mute yourself, please. Dr. Sardar, please mute yourself, please.
The host can mute him.
Yeah, so you can see that the flexion of the femur component, as I said, when you increase the flexion of the femoral component, you will decrease the posterior cut by 3 millimeters. So every 5 degrees of flexion of the femoral component will change the posterior cut by at least 2 millimeters. That's the importance of flexion of the femoral component, on which the mechanical alignment is completely silent, but kinematic alignment is cognizant of this fact of how to give the flexion of the femur component and keep it between 3 and 5 degrees so that your posterior offset is maintained. So this is a very important concept, and the kinematic alignment guys, thanks to Dr. Howell and all the people who have worked on kinematic alignment for opening our eyes on the flexion of the femoral component and its importance. Now again, the green is mechanical and the red is kinematic. And while mechanical alignment says that you external rotate the femur by 3 degrees. Why? Because you cut the tibia perpendicular, you externally rotate the femur component by 3 degrees, and you open up the medial space. While kinematic alignment concept is that you cut equal. Because you've given femur in valgus and your tibia is in varus, you cut equal and just resect what you are replacing. It's very simple. You cut 8 and 8 millimeters from the posterolateral and posteromedial. Even if you're not using technology, you can keep 0 degree to the PCA or 1 degree internal rotated to the PCA. Now the transepicondylar axis is of no value in kinematic alignment. Is of no value. Insole boot is of no value. What is of value though is that you recreate the posterior condylar joint line which is perpendicular to the flexion extension axis of the knee. By cutting equal posteromedial and posterolateral, the concept is very simple. And once you do that, you will cut like this. So your distal lateral cut will be 8 millimeters. As you can see there, the distal medial will be 6 millimeters or should be 6 millimeters. Posterolateral, posteromedial should be equal, 8 millimeters. If there is loss, then posteromedial should be 7 millimeters. And tibia has to be 8 millimeters from the tibial spine. Very simple. And then you will need no ligament release because you have reproduced the varus on the tibia and you have reproduced the perpendicular joint line to the flexion extension axis of the knee. If you use technology, well and good. If you don't, you should measure your cuts and try and cut equal. And believe me, all of you will see the wonder the kinematic alignment does, and you will need practically no ligament release. Okay, let's proceed. Now what you will do here is, when you cut your tibia and varus and you cut equal posteromedial and posterolateral, you will create a rectangular extension space and not a trapezoidal extension space which you are creating by cutting perpendicular to the mechanical axis. And your flexion space will be trapezoidal. So normally in mechanical alignment, which is again the green shade and the red is the kinematic alignment, the flexion space is also rectangular in mechanical alignment because you cut the PCL mostly and you have cut more from the posterior medial side. So your rectangular, the flexion space is rectangular and your extension space is also rectangular. But in kinematic alignment, your flexion space is trapezoidal because your PCL is intact. And you'll just see here in this video that the PCL is intact and the lateral side opens more, just like a normal knee. So what you're trying to give is recreate normal kinematics as much as possible and not release MCL, not release the PCL and create a rectangular flexion space. That's the most important concept of kinematic alignment, which is practically non-existent in mechanical alignment. Now, mechanical alignment makes knee a uniaxial joint. What that means is that our mentors taught us to just look at the flexion extension or axis of the knee. Just look at the flexion and extension of the knee. While kinematic alignment reproduces not only the flexion extension, but the internal rotation and the external rotation of the tibia on the femur. I'll just talk about it. And the AP translation. So not giving an anterior drawer or a negative anterior drawer is a very important concept of kinematic alignment, while mechanical alignment is again silent on this. And in mechanical alignment, it suffices to just see the flexion extension of the knee. While in kinematic alignment, it's important to see the internal rotation and the external rotation of the knee, as you will see in this diagram, as you will see in this video. And you can see that the tibia beautifully internally rotates in flexion because you have not released the MCL, you have not released the PCL, and you have not touched the retinacular ligaments. So the tibia beautifully internally rotates by about 14 degrees in flexion. Sorry for that. And here you can see that the rollback is also there. So the tibia is pivoting medially and the femur is roll back in flexion. So you can see that the femur is rolling back in flexion laterally and pivoting medially. And in that video, you can also see how beautiful the rollback is replicated because you have not released any soft tissues. And finally, the tibia internally rotates in flexion. Now, mechanical alignment is silent about all these very important concepts, which kinematic alignment beautifully highlights. And you can see, reproduce it in every case once you start doing it. And there is a criticism of kinematic alignment. I've seen people showing in their slides that kinematic alignment is of leaving the knees in varus. If you look at all the studies of major authors over hundreds of cases, you cut the femur in average 1.5 degree valgus and tibia in average 3.5 degree varus. LDFA plus MPTA, usually your HK will be within 2 to 4 degrees. So it's not leaving the knees crooked. It's a misconception that kinematic alignment is leaving the knee crooked and unbalanced. No, it's leaving the knee absolutely balanced in extension, and the HK normally it will come between 2 to 4 degrees because your MPTA plus LDFA measurement 1.5 degree valgus on the femur and 3 or 4 degree varus on the tibia will give you average 2 to 3 degree varus overall. And the beauty of kinematic alignment is that the single leg stance X-ray, we take bipedal stance X-ray. The single leg stance X-ray, if you see, because of the knee adduction arm, it will be parallel to the ground. This is an example where the single leg stance X-ray in a kinematically aligned knee, you can see is beautifully parallel to the ground. While if you take a single leg stance of a mechanically aligned knee, you will see it pointing up. So the joint line is actually reversed in mechanically aligned knee, and kinematically aligned knee, single leg stance X-ray will be parallel to the ground. And that's another very important concept of gait, that the gait kinematics are reproduced. Now this is a classical, I did this other side on this ideal navigated assisted mechanically aligned knee. And the other side is kinematically aligned. You can see that the tibia is about 3-degree varus, but the overall HK is still 2 or 3-degree varus. So basically, it's not releasing any ligaments, cutting equal distal medial, distal lateral, posterior medial, posterior lateral, equal tibia from the spine, not releasing the MCL or PCL. And surprisingly, you will be surprised, and so was I, but now having practiced KA for last 3-4 years, the patellar tracking is beautiful. And the reason is that you are actually not lateralizing the femur and your Q angle is maintained. So it's another misconception that femur external rotation facilitates patellar tracking. It does not. It does not. What actually reproduces patellar tracking is maintenance of Q angle. Once you maintain the Q angle, your vastus medialis pull and the length is maintained, and that is what facilitates patellar tracking. So does preservation of PCL, because when you preserve the PCL, the tibia internally rotates in flexion and facilitates patellar tracking. So these are the major differences between KA and MA. So once you are not shooting for a straight HKA in kinematic alignment, you are shooting for the natural HKA. What is natural? How do we know what is natural? By cutting equal amount of bone distally, posteriorly, and from the tibia. And if you are using technology, that becomes all the more easier because you have objective data in front of you. So you cut equal, as I said, you preserve the PCL, which is very important facilitator of internal rotation of the tibia and hence the patellar tracking. You create a rectangular extension space. There is no compromise on the extension balance. So no lateral laxity is accepted. Absolutely rectangular extension space, the knee perfectly balanced and solid in extension. A trapezoidal flexion space because you need the more lateral flexion space for femur to roll back, and pivoting medially because you're not released any MCL. Maintenance of offset, there is offset between the femur and the tibia, and that needs to be maintained, usually 8 to 10 millimeters, which is not possible in mechanically aligned posterior stabilized knees. Rotation, there is no challenge of rotation because you are not referencing the interepicondylar axis. You are basically cutting equal posterior medial and posterior lateral, and your tibia falls back because you're not downsizing the tibia and over externally rotating. So basically, you are not doing anything to the tibia. Downsizing is a mechanical alignment concept because to open up the medial space, you need to do all the work medially. Here you cut the tibia in appropriate varus and your ligaments will just fall beautifully in place, and you don't need to do any ligament release of MCL or PCL. And patellar tracking is very harmonious in kinematic alignment knees because the PCL is intact, the Q angle is maintained, and the patella tracks beautifully. And literature is quite evident that the rate of lateral release is much more in mechanically aligned knees than in kinematically aligned knees. And your X-rays will look beautiful. When you take full length X-rays, single leg, you will get X-rays like this. Joint line will be parallel to the ground on single leg. On bipedal, it will be pointing distally, mostly CPAC 1 and 2 type of knees, which are mostly in our country, where the apex is pointing distally and not proximally, just like in mechanically aligned knees. Dhanasekara, how much time do I have? Have I finished my time or?
You can continue for another 5 minutes. No problem.
Another 5 minutes? Okay. Yeah. So as I said, only we take this full length X-rays for coronal alignment. But you'll be surprised that in only 30% of our stance, we are in bipedal stance. Mostly we are in single leg stance. We are walking, we are going up and down stairs, we are sitting. So this mechanically aligned concept of getting a neutral HK is only valid for 30% of our gait cycle or of normal movements. Normally, we need much more than that. We need to understand we need to understand the importance of the flexion of the femur component, the cutting equal bone and not doing any ligament release, which will give much better function and form to the patient. And patients, lot of literature is there now. Everybody can go home and read the literature that kinematically aligned knees have got better forgotten joint score, better VAS scores, and early recovery. And patient prefers the kinematically aligned knees to mechanically aligned knees. This is just a short video of how to handle a varus knee by kinematically aligned principles. So this is a robotic surgery, but you can do it conventional also by cutting equal amount of bone and measuring. Caliper is the best friend of kinematically aligned surgeons. Even when we are doing robotic surgery, we measure every cut and we can manipulate the cuts in such a manner so that we are cutting equal distal medial, distal lateral, posterior medial, posterior lateral, and the tibia. So here you can see the femur is in a degree of valgus, the tibia is in about 3-degree varus, and we will not need any ligament release there. And just quick word about the valgus knee alignment as well, because valgus knees, this is the main concept of kinematically aligned knees, that the interepicondylar axis is not the axis of the knee, but the true axis of the knee passes through the center of the femoral condyles. And the difference between these two axes is 5 degrees. 5 degrees. So we need to forget the interepicondylar axis if you're really believing in kinematically aligned principle, and just focus on the flexion extension axis of the knee, which passes through the center of the condyles. And femur condylar hypoplasia in valgus knees is again a misconception, because a lot of MRI studies have shown that there is no hypoplasia in the true sense, but there is just loss of posterolateral and the cartilage on the lateral side. So in valgus knees, in mechanically alignment concept, you would cut the femur in varus. That's what we were taught earlier by all our mentors. And once you do that, you are again doing what you were doing in varus knees. You are creating a iatrogenically tight lateral gap by cutting the femur in varus, and by over externally rotating, you are creating a tight lateral extension and flexion space. While in kinematically aligned knees, you do the other way. So you cut the femur in valgus, 1 or 2-degree valgus, the tibia in neutral, and then you don't need any soft tissue release. As you can see here, the knee is solid in extension and the gap is rectangular in extension, trapezoidal in flexion, and you get beautifully aligned knees. So I think I'll stop here because rest is all about kinematics and further. But just to summarize, that kinematically aligned knee is truly a 3-dimensional principle and not just a coronal static principle. It's a dynamic principle. It's a 3-dimensional principle where you cut equal thickness of bones, you preserve the PCL, you don't release the MCL, and in a valgus knee, also the rate of release of ligaments is much less, and you get the overall HK in varus knees 3 to 5 degrees, and in valgus knees 1 to 2 degrees. So that is, I think, my summary of kinematically alignment, which is truly a winning formula. And I think mechanical alignment will soon go to our history textbooks, and we'll be talking more of kinematically aligned knees and functionally aligned knees. Thank you very much.
Thank you, Anoop. Can you switch off the presentation? Can you come out of the screen so that we can see?
Sorry.
So there's a good and exhaustive presentation. So, but for the beginners, we need to make it a little bit simple. So for mechanical alignment, we say it is cut 90-90 and external rotate by 3 degrees. That's what we teach about mechanical alignment. In kinematic alignment, can you give a simple 2 or 3 line explanation?
Yeah, so when you are doing with a caliper, you measure all the cuts. So correct. In mechanically alignment, you put the intramedullary rod and cut, but you don't measure. Sometimes when you start measuring, you will realize you're not cut 9, but cut a 10 or cut a 8. So the most important thing is to measure the cuts and start with a -2 on the distal femur, because you need to compensate for the saw curve and the cartilage loss. So start with a jig on -2 and cut 8 millimeters distal lateral and 6 or 7 millimeters distal medial. So that will be 9 and 9 millimeters, which will reproduce the thickness of the femur implant. Posteromedial, posterolateral should also be equal, 8 and 8 millimeters. And the tibia has to be 8 and 8 from the spine, which will normally give you 3 or 4 degrees of varus. So instead of medializing the tibial jig, you lateralize the tibial jig so that you cut in varus 2 to 3 degrees and measure 8 and 8 millimeters. Once you do that, you will not need any MCL or any PCL release. And PCL needs to be preserved in all cases.
So that was a little bit technically describing it. So basically, you're trying to resurface the knee,
Right.
take into account the cartilage loss and resecting, measuring and resecting, so that you just put back what you're resecting, just to replace for the implant thickness. But you don't change the joint line. You try to reproduce the pre-orthotic joint line. You don't change the rotation. You're basically resurfacing and trying to reproduce the natural anatomy, so that your kinematic is not changed. So that's how we look at kinematic alignment. So what are the advantages of kinematic alignment or mechanical? You said we are not changing anything. We are not changing the Q angle. We're not changing the rotation. Ligament tension is maintained. So with that, what we achieve post-operatively?
So post-operatively, if you look at the literature, the earlier pain scores, the recovery, and the later on forgotten joint score, especially on long-term follow-up, is better with kinematically aligned knees. And we never talked of forgotten joint score earlier on. We talked of forgotten joint score only in unis, but now we started talking in total knees as well, because the ligament tension, length, and laxity is maintained. So I think the patients feel better. The patients walk better because they are not 0 degrees. They are actually in 3 to 5 degrees. So the patients walk better and they can perform high performance activities as well.
So the dissatisfied patients after TKR was relatively high. Previously, they described as 20%. Now it is 10%.
Yeah.
So with kinematic alignment, probably we can reduce the dissatisfied patient and improve the patient satisfaction. That is one thing. And you can increase the forgotten joint score. And probably in the hips, we say they have the high forgotten joint score. They don't remember when they had the hip replacement. For the knee also, probably with the kinematic alignment, we will be able to achieve it.
That's right. That's right. So, Dhanasekara, we had nothing actually between a uni and a mechanically aligned posterior stabilized knee. So, uni was minimally invasive, only replacing the medial joint. And then we suddenly had a totally mechanically aligned PS knee, cutting PCL and releasing MCL and all of that. Now we have something beautiful in between, which is kinematically aligned knees, PCL retaining and not releasing any soft tissue and resurfacing the knee. So I think that big space in between a uni and a MA PS knee was vacant. And I think that has been taken by KA CR knees. And we all see in this journey how beautifully the knees will behave.
Anoop, in a severe deformity with a bone loss, what is the philosophy when we want to adapt this like KA? As you said, we cut 8 mm, 8 mm both sides, but there's a severe deformity with bone loss. What should be our approach?
So approach will practically remain the same, sir. And you'll be surprised that we do it every day, 15, 20 degrees up to 20 degrees starting deformity, which reduces to about 8, 10 degrees after removal of osteophytes usually, can be easily be managed, because we are talking of severe deformity before releasing of osteophytes and before releasing of all the osteophytes in the tibial side and the femoral side. Once you do that, the deformity usually corrects up to 10, 12 degrees. And then it can easily be managed with the principles of kinematically aligned knees. And actually, you would be surprised that when you cut your tibia and varus, your bone defects is mostly eliminated. So you will not be handling too many bone defects with KA, because your femur is constant. But your tibia cut, you can increase by 1 or 2 millimeters, and with your cut in varus, your most bone defects will be eliminated.
Anoop, just a quick question.
Yeah.
Anoop, so your K will be using consistently a poly size, which is the smallest poly, correct?
That's right, 9, yeah.
Correct? You'll be using the 9, which your system you're using. Now, what is the outer limit of varus that you will accept? Because that's a philosophy on which restrictive K came in, right? So in your practice, what would you consider not going beyond for a tibial varus for that matter?
So my upper limit would be 6 varus on the tibia and 3 valgus on the femur. But Anil, there are very few cases we have been seeing our data. In the last 1 year, there have only been 2 cases where we have crossed the 5 varus on the tibia. So we start with 3. We remove all the osteophytes. We release the posterior medial capsule if it's associated with a fixed flexion deformity. And then if we are not balanced in extension, then we would give more varus from the tibia and go up to 4 or 5. But average varus, even in all studies you see, is 3.5 varus on the tibia, average.
So with robotics also, you are in a FFD with varus, you would release the posteromedial capsule both on the media, both on the tibial side and the femoral side, correct?
On the femoral side.
On the femoral side.
Yeah. So K is about not releasing ligaments, not soft tissues. So you can release the posteromedial capsule, but the ligaments, the MCL
capsule alone.
Capsule. To correct the FFD component of the deformity.
There's a question
but not cutting extra distal femur. Mostly we are not cutting extra distal femur.
Anoop, there is a question in the chat box. Can you see?
Sorry.
Anoop, what about the PS substitute people?
Sir, I don't know, but if you look at your registry, and you would find that CR must be increasing. I'm sure CR must be increasing.
No, I do agree CR is increasing, but those who are going to do a PS needs. And secondly, the balancing your PCL by all that polo test and other things, we don't need here or you don't need?
Yeah, so sir, the polo test needs slight modification. So pull out and lift off is still a standard test. But when you pull out, it should come out little laterally because your lateral flexion space is supposed to be trapezoidal. So it should pivot medially. It should not come out medially, but laterally it should come out 2-3 millimeters so that the lateral flexion space is maintained and you get a great femur rollback. So that's a slight modification of polo test that has happened with KA principles.
Anoop, there's a question in severe varus with bone defect. Do you still need to do a reduction osteotomy or not? Or you just avoid soft tissue release only? That's what the question is.
Yeah, so you can do reduction osteotomy. Mostly it's not required in up to about 10-12 degrees of final uncorrectable varus. But if the varus is more than that, then you would definitely need reduction osteotomy. But my cases of reduction osteotomy have decreased significantly. And I haven't done MCL pie crusting for quite some time now, which was very usual with mechanically aligned knees.
Definitely cutting a tibia in 1 or 2 degree varus has made life a lot of easier because it reduces the amount of medial tightness and you're able to balance better.
Yeah.
So that's an improvement over the last few years.
That's right.
So if you have a robotic system, we are really confident. Yeah. Otherwise, you need to be very careful measuring with the caliper and doing it accurately.
Yeah, but I think those conventional, it can be done. Only thing is you need to check at every step and measure at every step and then modify your cut accordingly.
And the bone defect part, I think that's also very good, as you mentioned. When you put a cut in the varus, probably you will be able to manage the bone defect even better.
That's right, sir. I haven't put a bone graft for last 3-4 years. I haven't, because when you cut in varus, you almost eliminate the defect. Finished.
So is there any place where you won't do a kinematic alignment?
Not really extra-articular deformity. A severe extra-articular deformity, especially more than 20 degrees in varus or valgus, that's one. A post-high tibial osteotomy, especially the conventional closed wedge high tibial osteotomy, where the tibia is translated and I really don't know where my joint line is. Those are the two exceptions where I would still fall on restricted KA or MA principles, is extra-articular deformity and a conventionally done high tibial osteotomy.
So anytime PCL is suspicious, is there any situation you come across where the inflammatory arthritis PCL is suspicious,
Yeah,
where we want to proceed?
that's right. That's a great question. So about 8 to 10% of cases, I would say 8% roughly, are the cases where the PCL is either compromised or there is a big osteophyte in a FFD case right in the substance of PCL, which you need to take out, or inflammatory. There you need to do a AS type of a poly, ultra congruent type of deep dish poly. But there is no need to cut a box actually, because you not release the MCL part. Only your PCL is compromised. So you need to put an anterior stabilized poly to compensate for that posterior drawer that you will have now. But box, for last 2 years, I've just done 2 or 3 PS knees. So that's a big change that you will feel in your practice when you start doing KA knees.
Anoop, in case of bilateral where one side valgus, one side varus, like wind swipe, as you said, we try to put them back into the original thing. So what would be the philosophy for this?
Great question. Great question. This question could only come from a real good thinker of the knees. So I would refer your question to McDessie's paper. He has published a beautiful paper on wind swipe deformity. So wind swipe deformity doesn't come naturally. So what he did was he took a normal population and then he took an arthritic population. So normal population does not have wind swipe deformity. So most of us are born with both knees aligned similarly, either in varus or in valgus. But none of us are born in one knee in varus and one knee in valgus. Okay. So the answer to your question is that you reproduce the varus side, considering that most patients are varus. So you would do 2 or 3 degree varus residual on the varus side and 0 or 1 degree varus on the valgus side. So you try and get both knees aligned similarly. While in both knees in valgus, suppose patient has both knees in valgus, there you can leave the patient in 1 or 2 degrees valgus on both the sides. So I hope I made myself clear.
Yes, you try to keep it in neutral if you have a valgus in the valgus side and keep it in varus the varus side.
That's right. That's
That'll be a simple answer. Okay, that'll be good. Yeah. Thank you, Anoop, for the interesting discussion and wonderful.
Anoop, just one more question.
Yes,
Yeah.
Anil.
Sorry, Dana, just one question. What about the ones with the slight recurvatum?
Yeah, so recurvatum, mostly you would decrease your distal femur cut and
Correct.
so
Yes.
recurvatum, Anil, are basically lax knees. We don't analyze them in weight bearing. But
So
when
you minimize your cuts?
Flexion, when you analyze them in flexion, they are loose knees throughout the range of motion. So essentially your tibial cut has to be 3 or 4 or 5 millimeters. And you
reduce cut.
Reduce cuts, and of course there are no ligament releases, and the
Yes.
PCL is a good restraint to hyperextension. And then you can use an anterior stabilized poly further on to prevent further patient going back into recurvatum. So those are 3 important tips for a recurvatum knee in KA philosophy.
Thanks, Anoop. So we'll move on to the next lecture from Dr. Anil. Another interesting topic, spinopelvic alignment in THR. Anil is a professor at Christian Medical College, Vellore, and is a well-known speaker in orthoplasty. I welcome Anil to give his lecture.
Thank you.
Dr. Indrajit Sardar? Dr. Sardar is there? No. Okay. Anil, just give me a minute before you start your talk. I would like to request all the delegates or listeners, those who are there, young surgeons, please contribute to the Indian Joint Registry. It's very important. Be the member of Ishks. You may be listening to the good talks which is coming every month. But on behalf of all of us at the Ishks Managing Committee, we would request you to become members of the Ishks, number one, and try to contribute to the Joint Registry. Please spare some time. It's not a time-consuming things, and registry data are very useful for the future of all of us. So please do that. Over to you, Anil.
Thank you, Dr. Dipak. Thank you, Dana. Thank you, the entire team. I think from that wonderful talk on alignment philosophy, move on to the hip. And this is one topic that has been debated and also redebated and still being debated. So I think this is one topic that needs a little consideration also. And I think we need still, sort of grappling with the actual implications it has on total hip arthroplasty, especially in our scenario where we see so many complex hips. But the simple principles, if we adhere to, I think we will be able to actually adjust or keep information that is required and then do the necessary as we execute a total hip arthroplasty. So going on to this, keeping in mind that we are having a lot of fellows and also young surgeons who are probably new to this concept, I'll try to keep it as simple as possible. So basically, when we look at the screen is visible, I presume. Dana?
Yeah, it's visible
Okay. So when we go to what we call spinopelvic mobility, we also understand that pelvic mobility depends on spine mobility. It has three components to it. It's a pelvis, you have the spine, and you have what we call the spinopelvic junction. So let's look at what exactly happens in the normal individual. So when you are standing, you have what is called an anterior pelvic tilt. And when we are sitting, we have what is called a pelvic that tilts posteriorly. So this is the fundamental understanding we got to start with. We have a pelvis that's tilting anteriorly on standing and a pelvis that is tilted posteriorly when we sit down. Now, what happens to the spine at this stage is also important. First, let's stay to the pelvis. Now, because standing and sitting depends on the spine mobility, different individuals may have different orientations of the pelvis. For instance, in some individuals, there could be an anterior tilt to the pelvis, and some individuals, there could be a posterior tilt to the pelvis. And that invariably shows orientation or a limitation in their spinal mobility. It could be either a lordosis or it could be a loss of lumbar lordosis. And that is what reflects on the pelvic tilt. So that is why we have come to understand that each patient, each individual has a difference in the orientation of the pelvis. And that is where this terminology called functional orientation has come into existence. So which means could be patient specific. The pelvis could be tilted either anteriorly or posteriorly depending on the spine deformity or orientation. Now, this is what has given rise to a terminology called functional orientation of the pelvis. Now, to begin our understanding or to begin our assessment of spinopelvic mobility, a simple X-ray pelvis, AP, would be sufficient to give you a very good idea of what the lumbar spine is going to look like. So if you look at the pelvic AP, just look at the obturator foramen alone. On the right, you have a pelvis X-ray where the pelvic inlet is almost completely obliterated, but the obturator foramen is widely open. But on the left, you have an X-ray where the pelvic inlet is almost an inlet view and the obturator foramen is almost closed. Now, this is what was described as the cat's eye view, where either the eyes are closed or the eyes are completely open. This is what Ranawat was referring to as the eyes open or the eyes closed. Now, what does that tell you about the spine? Either in a pelvic inlet view, there is a fixed flexion deformity, and that is the reason why there is an exaggerated lumbar lordosis, or the spine itself could have a fixed lumbar lordotic curve. While the contrary is true, where the obturator foramen is wide open, and there could be definitely a loss of lumbar lordosis. So one look at a pelvic AP would give you sufficient information regarding the actual spine mobility or actual residual spine deformity. Now, mind you, the one on the left where you have an inlet view could also be due to a flexion deformity. But if there is a residual pelvic tilt as well, then it could be due to persistent lumbar lordosis. Now, how do we do the spinopelvic assessment? We do X-rays in both the sitting and the standing view, and we do a host of parameters that has been described, which is the sacral slope, the pelvic tilt, the pelvic inclination, and what we call the lumbar lordosis or the LL angle or the LL mismatch. Now, just to keep things simple, what we need to do is take an X-ray of the LS spine in the sitting position and the standing position. And to look at only one parameter, we look at what is called the sacral slope. Now, like we said in the normal individual, the pelvic tilts posteriorly on sitting and on standing, the pelvic tilts anteriorly. So as a result, there is a change in the pelvic, or what we call the sacral slope. Now, if you look at this, there has been studies conducted extensively on what the normal variation is, and we have a change in value for pelvic incidence, for pelvic tilt, and the sacral slope, which goes through a change from sitting to standing. So in effect, if we stick to sacral slope alone, we can see that normal spinopelvic motion, there is a change of 10 to 30 degrees change in sacral slope from sitting to a standing position. So this is the fundamental understanding that we got to begin with to look at what is spinopelvic mobility. Now, if you look at what are the implications on the pelvic tilt, now if you go changing from supination, from sitting to standing, you also have the acetabulum that changes with the pelvis. Remember the acetabular component, if it's implanted into pelvis, there is change in anteversion and inclination that occurs with this pelvic tilt. Now, if you look at what happens from sitting to standing, there is a change of almost 41 degrees inclination and 10 degree of anteversion in the standing position, and a 54 degree inclination and a 38 degree anteversion to the sitting position. Now, this is the change that occurs from sitting to standing. So when we put in a cup at 45, it doesn't stay at 45. It goes through this change from sitting to standing. So that is why we got to be wary of putting in a cup exactly, or even if there is an error in putting in a cup, that can have significant implications of what the cup inclination and anteversion could be from sitting to standing. And that is why all the more reason, when there's a spinopelvic abnormality, we should be more attentive to placing our cups in the correct position. So to simply put, there's a formula that has been described. That is, every change in pelvic tilt of 10 degrees will cause a 7 degree change in version and a 3 degree change in the acetabular inclination. And this is what we got to bear in mind. So simply to put, when a patient is in the standing position, there is an anterior pelvic tilt, and that is referred to from the cup point of view. There is what we call a functional retroversion. And in the sitting position, there is a posterior pelvic tilt. And what happens to the acetabulum is there is what we call a functional anteversion. So in the sitting position, what we have to remember is it could be an increase in anteversion. And in the standing position, what happens is there could be an actual retroversion or a loss of this anteversion. And this is what we got to bear in mind. So what happens if you go ahead and put your cup in the normal position, say in 40 degrees or in 40-45 degrees? There may not be a frank dislocation, but what could happen is there could be what is called an impingement. And this is what you want to avoid, because that could lead to edge loading, and that could lead to also problems with leading to impingement, leading to dislocation. And that is why we want to make these adjustments for spinopelvic mobility. Now, just to show common examples that we have and how we also came to understand and look at these situations a little better. This is a 32-year-old male, several years back, with angst, fused hips and fused spine. If you look at it, he's got a loss of lumbar lordosis. We went ahead and did what we call a cemented hip arthroplasty. 3 months later, he dislocated. It was not because he had a significant trauma, not because he had anything significant. One not so significant trauma, he dislocated. He was not amenable to a closed reduction. We had to go in and do an open reduction. And when we did an open reduction, we realized that probably our anteversion of the cup was little more than what we had to implant it in. Fortunately, because the cup was so well fixed, we did not revise the cup. We reduced it, made sure it's stable, but explained fully to him that if there was a significant problem, we would have to undertake a major revision. Fortunately for us, he came back at 9 years follow-up. We understood that we probably should have paid attention to the anteversion. He did not dislocate further. It's also because these angst patients do not dislocate that easily, but probably we needed to have paid a little more attention to the anteversion of the cup. Now, this is another typical example. Again, we have a pelvis that has lost its tilt. You have eyes wide open. And if you look at it, this patient had to undergo a hip arthroplasty on both hips. And this is what was done. And keeping in mind that the lumbar lordosis has been lost, we undertook what is called a uncemented total hip on both sides. And we paid attention to the fact that the anteversion should not be increased. And in other words, try to reduce the anteversion as much as possible. She's almost 4 to 5 years. But what we could do and what we could be increasingly aware of was that we had to pay attention to the fact that there was no increase in anteversion so that the patient could have a deleterious outcome. So in a situation where there is a loss of lumbar lordosis, where the sacral slope is also static, which means there's no change from sitting to standing, as demonstrated in this patient post-op, we have to pay attention to positioning the acetabular component a little more carefully. So let's come to what we see in these particular situations. We started analyzing these patients. Now, this is a typical Angst patient pre-op. Now, look at him. He's able to sit. He's got stiff hips. He's got reduced hip spine mobility also. But if you manage to take an X-ray from sitting to standing and you study or look at only one parameter among the other parameters that are studied, you look at the sacral slope alone. The sacral slope has hardly changed 5 degrees between sitting and standing. Carried out the hip replacement. Now look at him post-op when he comes for a follow-up. If you look at it, now from sitting to standing, again, the change in sacral slope is very negligible, which means that the change in sacral slope from sitting to standing has been less than 30 degrees, or the sacral slope has been 30 degrees or less than 30 degrees in both sitting and standing, both pre-op and post-op. And this is a particular group of patients that have a persistent posterior pelvic tilt, and they are referred to as a stuck sitting individuals. Now, what happens in these situations, if you don't pay particular attention to the anteversion, technically there's a loss of hip extension. And they could have a posterior impingement and they could have what is called an anterior dislocation. And this is what we have to bear in mind if we do not pay attention to the anteversion and inclination. So in an Angst situation, which is stuck sitting, there's no change in the sacral slope, there is a risk of posterior impingement and anterior dislocation. We remember that there should not be a situation where we increase the anteversion of the cup. In fact, keep the anteversion as minimal as possible in order to prevent that posterior impingement and anterior dislocation. And this is what we have to bear in mind when there's loss of lumbar lordosis. Look at this situation. You change from sitting to standing, where you have a sacral slope inherently more than 30 degrees, both for sitting and for standing. Those are referred to as a stuck standing position, because whatever you do, whether you sit or you stand, the pelvis is permanently stuck with an anterior tilt. And this is what is referred to as stuck standing position. What happens in this situation? This is another set of X-rays to show you a stuck standing individuals. There, the sacral slope is more than 30, both on sitting and standing, even after doing the hip replacement. So obviously the spines have become stiff. And that is why what happens is, actually speaking, there could be a loss of flexion. And if you further flex or do anything that increases the flexion, there could be what is called an anterior impingement and what we refer to as the posterior dislocation. Persistent lumbar lordosis, if your anteversion is not right or if you've underdone the anteversion, it could be anterior impingement and posterior dislocation, if not edge loading. So these are situations where you want to probably minimally increase the anteversion, obviously within the acceptable limits, minimally increase the anteversion so as to prevent your anterior impingement and a posterior dislocation. So there are two ends of the spectrum. You have a stuck sitting or a stuck standing. So coming back to what we have to see to simplify the matter, you look at a pelvis AP, both the inlet views or the outlet view, you have to decide whether your spine has either lost its lordosis or maintained its lordosis. Now, the problem is in the Angst patients, there's a host of spinal deformities that we see. It's either in flexion or in extension. So it could be a confusing picture. But eventually, you have to pay attention only to the sacral slope, because the sacral slope will tell you what exactly the spinopelvic mobility or the unit of the spinopelvic mobility has to say about the spinopelvic mobility parameters. So that is why we have to see whether, as a rule, in all these Angst patients, there is a decrease in the spinopelvic mobility, which means the normal change in spinopelvic mobility from sitting to standing does not occur, and it might not be even typical of any pattern, but there could be a reduced spinopelvic mobility. So to go back to basics, take an LS spine, lateral sitting and standing, and the recommendations when you have normal spinopelvic mobility, which is between 10 to 30 degrees, is that you have to put in your cup at your inclination of 35 to 45 and your anteversion of 15 to 25, and your combined anteversion of about 45 degrees, you would have a good optimal long functioning hip outcome. But if there is a persistent lumbar lordosis, which is a stuck standing position, remember you have to put it at the outer border of anteversion so that you would reduce the risk of what we call an anterior impingement and a posterior dislocation. And that is what you want to avoid. In order to avoid an anterior impingement and posterior dislocation, you got to pay particular attention to the cup, especially when there's a fixed lumbar lordosis. You would not want to put that cup in reduced anteversion. You would want to put it in the correct anteversion, probably in about 20 to 25 degrees. Basically, not make an error in under anteverting the cup. So in the Angstmont sort of scenario, where you see that loss of lumbar lordosis, stuck sitting position where there's a risk of posterior impingement and anterior dislocation, obviously you do not want to increase the anteversion because there is a risk of posterior impingement and anterior dislocation that can occur. So you would put the cup in minimal anteversion. You would take care not to excessively antevert the cup because of the fact that there can be a loss of extension and that can result in posterior impingement and anterior dislocation. So just to show you a few examples where there's absolute loss of lumbar lordosis, a typical patient coming to you, loss of lumbar lordosis, both in sitting and standing, the sacral slope is almost reached single digits. So these are situations where there could be a risk of posterior impingement and an anterior dislocation. And hence, we have to pay attention to the cup where we shouldn't by any chance put in a cup in excessive anteversion. Always doubly check the position before you make your final adjustments. And in fact, literature has come to say that if you're not sure of your anteversion, please go ahead and put a dual mobility. But we don't need to do dual mobility for all hips. If we are carefully paying attention to what we call the anteversion and the inclination in these particular scenarios, either in a lumbar lordotic increase scenario or in a loss of lumbar lordotic scenario. So pay attention to what we call the lordosis or the spinopelvic parameters. Put it at the outer limit of anteversion where you have a persistent lumbar lordosis and a decreased anteversion or a minimal anteversion where you have a loss of anteversion, especially, or loss of lumbar lordosis. We studied all these hips, especially in the ankylosing spondylitis spectrum. We studied about 58 patients with about 100 hips, and we realized that majority of them are stuck sitting. So we needed to pay attention to these anteversion and inclination parameters so that we do not have an error in implanting these cups or in these acetabular position. So this is also seen, and this has also been described with our modified lateral approach, which we also have published. So take-home message is that spinopelvic mobility is important and cup adjustment has to be done with care using the routine landmarks and technique if navigation is not available. Also to add a few points that do we need spinopelvic mobility for all patients? No. It is only for patients who have had either a strong history or on treatment for inflammatory spondyloarthropathy or have undergone a spine surgery for any sort of disc problem, or patients, especially in the elderly age group, who have undergone degenerative changes and could also have a persistent spine problem. Not for all patients you need to do spinopelvic assessment, especially with the spectrum of patients coming to us. And there is newer literature emerging that there is changes in spinopelvic mobility with advancing age, which means degenerative spines display a loss of spinopelvic mobility. And that also has to be taken into consideration when we assess, especially patients who are coming in the older age group or with history of a degenerative listhesis or any other situation that would be ready for a total hip arthroplasty. Thank you for your attention.
Thank you, Anil, for again a wonderful lecture. Very difficult topic. Every time you listen to it, it feels as though you're listening for the first time.
Yeah, every time we go through this, I think every time you learn something new, especially when you get through these things again. Yes.
Anil, this is Leo.
Yes, Leo. Hi.
Yeah.
How are you?
Hi. So I think that was a fantastic lecture and amazing graphics. I don't know. I need to get your help on where to get those graphics
Oh,
from.
those are all available online. There's not anything
Yeah.
that is not my creation anyway. All online. Okay.
Yeah. So I have a question for you. Now, you do say that there is a role for modification of the anteversion based on whether it is stuck sitting or stuck standing, and that those are the situations where you would like to think of either increasing or decreasing the anteversion. So when you say if it is stuck standing and you're worried about anterior impingement and posterior dislocation, how much of anteversion would you really give, and how would you decide on how much of anteversion to reduce? Would you like say you're going to put it neutral or in retroversion? Have you ever come across that situation? Number one. Number two, if you are moving your joint, say for example in the lateral position, and then you're going through a full range of motion, you're able to take it to about 20 to 30 degrees of internal rotation. If you're, for instance, doing an anterior approach, that's the usual degree you go to. If you're doing a posterior approach, maybe 45 degrees of internal rotation at about 90 degrees of flexion, and you're able to take it to as much external rotation as possible without impingement. Then do you think whether it is stuck standing or stuck sitting, will that affect your post-op instability? Because if you talk to people like Dave Fisher, he says you put it through a full range of motion operatively, you make sure there is no impingement, no matter whether it is stuck sitting or stuck standing, I don't think it is going to come out. So do you think there's a role then?
Yeah, that's a very relevant point, because actually speaking, intraoperatively, you're not going to recognize what exactly occurs at spinopelvic junction. And that is because your spine, remember, rigidly immobilize your pelvis when you're taking your range through taking yourself through the range of movement to check what is called stability. So if your components are in the correct position, that's not going to dislocate. That's definitely not going to happen. Okay. So your adjustments are for what is going to occur after the patient is off the table, because that is when the spinopelvic unit starts coming into play. So what you're testing on table, presumably you're rigidly immobilized the pelvis, okay, and then you're taking it through a range of movement, whatever internal rotation, whatever external rotation, and you're trying to see whether there's any edge loading and things like that. So that is absolutely true. You're taking it through that range, you're trying to see whether you've got the parameters right. But what is going to happen when the spinopelvic unit is also coming into play is what is important. So when the patient sits or stands, and like we said, that will change the cup orientation, correct? So that will not be assessed properly when the patient is on table. So the cup orientation keeps changing from sitting to standing. For example, if somebody is coming with a stuck sit position, he can actually, if you err on the side of slightly increasing the anteversion, he might not dislocate, but you'll have evidence of, if you've wrongly got, obviously if you put your cup in excessive anteversion, he's going to dislocate anteriorly for sure. But there's going to be some amount of edge loading, correct? So you want to prevent that. So in what we do for all routine hips, for non-complex hips, we do an anterolateral approach. In an anterolateral approach, you tend to excessively antevert your cup if you're not careful. So we definitely don't put it in retroversion. We do identify the TAL. We do use the instrumentation guides that are provided. Each of them have these instrumentation guides that are provided, whichever set you're using. And with a combination of that, we try to reduce it, which always means that we are trying to put it towards 5 to 10. We've done CT scans to assess the anteversion after THRs. And we've realized that in fact, for that set that we published, we did the CT scans for them, and we've realized that our anteversion was indeed come down to about, and it was not 15 to 20, it was averaging more than or around 10 degrees actually. So if you don't have robotics, if you don't have imaging, as most of us don't use technology, I think it's better to have a combination of your landmarks with your instrumentation guides to make a conscious effort to reduce the anteversion and not increase the anteversion.
If I can just ask a little further on that. So the logic of stuck sitting and stuck standing is that the spinopelvic mobility is very restricted in those patients.
Correct.
Now, you did say that when we are testing peroperatively, we have a rigidly immobilized pelvis. So if you have immobilized that pelvis, if it is either a stuck sitting or a stuck standing, it is going to remain in that position no matter which position you do it in the lateral position. The spinal pelvic mobility is not going to change. Correct. We are not going to alter the spinopelvic mobility from where it is going to be. If you have about 2 to 3 degrees of range of motion, that's the maximum that you can take it to. So There are people who argue that there may be an element of overrating of the spinopelvic
Yes.
problem as well.
Exactly.
So the logic then should be that if peroperatively, maybe stuck standing or stuck sitting, but if you take it through a full range of motion peroperatively without impingement, then the chances that that hip is going to dislocate are as good as any hip. So do you think there is a logic to that argument?
So now, Leo, we have come to a point where all of us understand the parameters. We are putting in the problems. We are putting the hips. We are not. I'm sure everyone on the panel, everyone will agree, and you will also agree that our dislocation rates are no longer worrying because we're getting our parameters right. What we are worried about is putting the component in correctly to prevent polywear or prevent edge loading. And we are trying to increase the longevity. How can we do that? That is a question. We are not talking about dislocations now too much because all of us have, in some way or the other, with technology, without technology, everything, we are all getting our positioning right. We are checking, double checking. I'm sure all of us will agree that we don't see dislocations like we used to see before because of our own execution and our own parameters and testing. What we are definitely trying to see is how we can prevent eccentric wear of the poly, edge loading, and things like that. And especially in these group of patients like angst-pond or who have got other issues. As you rightly said, there are recent literature coming out saying spinopelvic mobility varies with age. Age has a dependence. So is it really relevant? Because remember, you put it in a particular position, advancing age, you will have changes again. So that is also coming into the picture. However, it is better to assess preoperatively to know what is the situation so that you can take appropriate care in not excessively antiverting or under antiverting as appropriately required. Pay attention to the acetabular component, I think, is the bottom line. That is the bottom line. Anoop, I think there's a question. I'll come back to you, Leo. Anoop,
So, hello.
Yes, Anoop.
Yeah. So, Anil, the recommendation for the normal spines versus a stuck standing and a stuck sitting varies about 10 degrees of version. If you see the recommendation.
Correct.
10 to 15 degrees.
Correct.
Now, how on the table can you really ensure that you are that 10 degree less or more verted unless you are using technology?
Correct.
And how can you also be sure unless you take a post-op CT scan that you achieved what you aimed for? So to put all this in perspective, the spinopelvic assessment and its execution, isn't it then necessary to use robotics? And then get the CT scan and then get the impingement correct and then get the inclination and version to your recommended levels.
So there are two solutions to that. Simple solution is basically they're saying use dual mobility for all these hips. So you don't worry about antiversion anymore. The West, actually, the other groups have said where there's a problem, you put it in the normal position, judge your parameters, like Leo said, take it through a full range. So to prevent any issues, use a dual mobility. But that has not been agreed by all forums. Okay. Now, the other option, like you said, yes, use navigation, use technology. That's the best way to get your 10 degrees versus 20 degrees or 10 to 15 degrees. Now, for the majority of us who are, or majority of all surgeons or across the world who are non-technology users, the only option would be to use a combination of landmarks, your instrumentation guides, and also because we have done CT scans post-op, you can assess. I mean, like you said, CT scans post-op for the cup, limited CTs will study your position and to see whether you've got it right or wrong, or intraoperative imaging. But again, intraoperative imaging is not foolproof. So your only option is CT scans to assess whether you've got your antiversion correct or not. Now, having done that, intraoperatively, what is your test? It's only going by the TAL. You're going by, even in fused hips, you identify the TAL, identify your landmarks, put it in correct. In fact, for that matter, most Walkchick and group, they say implant the femur first. Go on to the acetabulum, go the trial, put in your trial components only. You can provisionally get your trial components and then adjust finally and then put in your implantation. So there's so many ways to do it even without technology. But definitely, there's no doubt about it that it is only, I mean, if you want to get exact figures, it is with technology. But there's another glitch to that. If you want robotics to be used, especially in angst-pond, most situations, the patient will not be able to get a proper sitting X-ray. So you need two values even in robotics. If you use a robotics, you need two values where it's an image-based system. You need sequestro both in the sitting and standing position, which may not be available in all situations.
No, in Ankis Pond, you can get a sitting X-ray. I mean,
If the hip is significantly fused,
both.
and most of them who come very delayed, they won't be able to get a proper sitting X-ray.
Yeah, but so we are using Mako robotics for hips now, but most patients we can get those sitting.
Yeah, but what happens to the patients who can't sit?
That's right. So yeah, that's the rare category. But
No. I mean, there are still enough in those category, or you don't get what you call the optimal sitting X-ray.
That's right. Yeah, I agree.
They get it. So that is why even technology actually will not provide the maximum information. So these are situations that we all know, because especially for the angstpond who are coming late, they sit in various degrees of extension. You don't get an optimal sitting X-ray.
I agree. Yeah.
Anil, do you think there is a greater worry with regard to spinopelvic mobility in those patients who have already undergone a total hip replacement, who subsequently undergo a spinal fusion? And then that alters the way that the hip has been performing all these years. Because when we are doing a total hip and we already have a stiff spinopelvic association there, we know where we are putting it in and how much of stability there is. But then we do a total hip and then the patient subsequently goes in for a spinopelvic fusion, and then the dynamics are significantly altered from what they were designed to be during the primary total hip.
So, there was a time when I think the spine surgeons were quite, at least across one forum, they said, oh, spine surgeons are the biggest devils. After you do a hip arthroplasty, like you said, after several years, undergo a spine fusion, and then they come to you with dislocation. So, to offset that, I think there is a significant role in getting your parameters correct. So I don't think they will frankly dislocate if you've got your parameters wrong. Like I said, we are paying more and more attention to all these parameters now, Leo. I think there's only a question of having a little bit of edge wear or a little bit of loading and things like that. So right now, these are all the patients who have undergone THR several years back. Probably there was some error in putting in the component and now undergone a spine surgery, now come to you with dislocation. So that would be a different category of patients. I'm sure that now, with all this attention and all this knowledge that we have, irrespective of the fact that we have technology or not, we have this ability, all of us have the ability and the wherewithal to put in the component in a correct position. So that shouldn't be a problem.
Having both the symptoms, like a hip spine syndrome, do you think that they should go for spine surgery first?
Very good question, Dr. Dipak. So I think the primary situation, I think, like has been described, if there is significant pain that symptomatically, if there's from the spine, and the only way to differentiate, actually, one of the things that we can do is an image-guided injection of local into the hip. If that is going to provide some relief, then the patient, at least the patient is confused as to where the pain is coming from. If there's not going to produce, I think the spine should be definitely addressed first before the hip. So I think when the hip spine syndrome is there, it is better to get the entire evaluation done from the spine side. And if any doubt at all that there is the spine symptomatology is over and above the hip symptomatology, that has to be addressed first, because that can be taken care of, then the hip can be taken care of subsequently. Then we can also pay attention to the parameters as required. Yes, Dhana.
Dr. Pachore?
Yes. Hello.
Yes, Dr. Pachore.
Yeah, yes. We're waiting to hear from you.
No, 2-3 things.
Yes, sir.
Basically, what Anil says, right, that every patient does not need the X-rays of the spinopelvic parameters. One simple test, just get a forward as the patient comes, look at the spine. He is not able to go with that. Then and then only you can take the your sitting and standing X-ray. I do agree with Anil that every patient does not need to go through all this. Number 2, I agree with Anil is ankylosing spondylitis. You are not going to get enough information of sacral slope because they are very stiff. Hip does not allow, so we will not be able to get enough. That is number 2. And I agree, Anoop, that probably we will be able to, the navigation of the robotic may help us. But probably this entity looks to be overwritten as far as I am concerned as a very senior man. So probably the youngers probably will take it in a different way. That is another thing.
participant I teach.
Very important thing is if a standing it does not show more than lateral slope, then I think you should work out whatever you would like.
932.
So that we have to analyze.
2521.
Spine surgery first or this.
7668.
Now new parameters. So if they are, the spine should be tackled first and then hip should be the second choice, because reverse way doesn't happen there. Very difficult to revise the spine, becomes very difficult. That is another important. We must thank actually Dr. Suryaban. He is the first person in the literature showing that anterior, he did a lot of posterior, he did a posterior approach and he had a 3 anterior dislocation. And then he realized that there was excessive anteversion and that there was a kyphosis. I think we must thank and give credit, all credit to Suryaban as far as this is concerned. The other important thing, why ankylosing are not dislocating too much, even though there are young surgeons, we are not able to exactly maintain the anteversion and everything, because they don't have that impingement range. That's why the dislocation rate as such is very, very low. You imagine, Dr. Dholakar did, we had that time, we were 22 millimeter head, and he did, I think, about 350 plus at the surgery at that time with 22, and he hardly had any dislocation rate in spite of 22. We were not knowing the anteversion, the spinopelvic parameter, nothing we were knowing. So that is the reason that probably they don't get range of motion that high. Number 2, today, we are not using now 28. We are most of the time 32, 36. So that also has reduced the rate of dislocation. But there is no question that we must use the technology of and very clear one single picture what Anil shows, either stuck in standing or stuck. That will give a fair degree of idea whether the patient has got kyphosis or lordosis. That is another important thing which one should keep in mind.
Dr. Sardar, yes. Indrajit, are you there?
Yes, Dr. Pachori, I think what you said is very relevant, because I think the days when we also started out, it was with the 22 heads, and we realized that hardly any dislocated. It is just the 1 or 2 that have dislocated. We came back. It was so difficult to reduce. We opened it and then we realized that the anteversion was a little more. That's when we probably started looking at all these things. I don't think before that there was, and what you said is very true about Angstpond. It is also to do with their soft tissues. It's also to do with the general thing. They most of them come, by the time they land up for surgery, they're in significant deformity. The soft tissues have also undergone significant change. So even the range of movement that they get a good range of movement, but they definitely do not go to the extremes. So that is also one thing. And the soft tissues have also undergone an element of plastic deformation. So dislocation rates are low, but these are all young individuals. So we would like to actually look at parameters or ways in which probably the longevity of these implants can be better, because in our country, you know that they all come with just budget. When you put down the hips in whatever position, in the sense, we should do something to increase their longevity rather than having issues too soon.
Anil, there has been some suggestions about technology.
Yes.
Do we have validated evidence to suggest that robotics is good enough in accurately predicting and reproducing the ideal personalized alignment of a cup for an individual patient as yet? Because these robotic systems are all different. I think they have different ways of getting the job done. Do we have sufficient evidence to suggest that they're really good enough to reproducibly predict and provide the right amount of right alignment for an individual patient?
I think what has been put out is that, first and foremost, is that this concept of functional orientation and personalized alignment, even for hips, has been put out by the technology group, whether it's navigation or robotics. But we should realize that these are all situations where all the parameters have to be fed in to get information out. And like I said, even for the image-based robotics, you have to feed in a sacral slope with both sitting and standing. What about the Angstpond patient who comes who would not get an optimal sitting view? Where would you get that information from? So that's also going to be, it's good when you have a good hip with a reasonable range of movement, where you can get a proper sitting and standing. But what would you do in a situation where the patient can't sit? That's exactly what I was telling Anoop about. So Mako system, I mean, whichever system you want, you need a sacral slope sitting and standing. Yes, technology will help.
Okay, Dr. Dhanasekara?
Yeah. So just I want to say this. I was agreeing with Leo, because the spinopelvic problem is exaggerated now. It was important when 15 years back we didn't have a spine X-ray when we did a THR. So when they look back, the incidence of dislocation, cause for dislocation, the patients who had a spinal fusion with Harrington rods, they were all straight rods. They corrected the lumbar lordosis, made it straight. These are the patients which dislocated. But once we started understanding the spinopelvic alignment, we are able to adjust by 10 degrees on either side, and the incidence of dislocation is almost come down. So I don't think there is a big role for technology for these patients. Even without technology, just understanding the spinal mobility, we are able to give good results for our patients. And always look at the spine, mobility of the spine before you operate a hip replacement. So take a spine X-ray, which should be a part of your investigation. And if it is already fused in stuck sitting, or if there is a hyperlordotic spine, we do a 10-degree adjustment. That's all is allowed. We cannot change it too much. 10-degree adjustment will help you.
I think just attention to the acetabular component is what is required.
There are a small rare condition there is inflammatory arthritis where the spine is not fused. We expect later the spinal alignment is going to change, or where the situation where you have degenerative lumbar spine where the alignment is going to change, where there is a small group where dual mobility can be used, so that in future it is reduce the risk of dislocation. So this is the present understanding. So with which this will conclude this session, sorry, extensive discussion. Thank you all faculty. So the next meeting is going to be on December 21st. It's a Saturday. Where December 7th, we have IACON, and December 13th, there is another meeting of orthoplasty. So next meeting is going to be on December 21st. I request all of you to join the meeting, and there are going to be interesting lectures. Thank you very much for joining. And I thank the Ishks trustees and Dr. Pachore and all the executive council for giving this opportunity to organize this excellent meeting. Thank you, speakers, Dr. Anoop and Anil. Thank you, Leo, Dr. Indrajit, and Dr. Pachore, and my colleague, Dr. Dipak. Dr. Dipak, you want to say a few words before we close? Dr. Dipak? I think he's in the railway station waiting for the train or something.
No, he's on the train, I think. Dr.
No,
Dipak
I think
yeah.
I will just say it.
Yes, Dipak, sir.
Be the member which try to
Voice is breaking, sir. So probably we want to enforce that all junior surgeons to be part of the IJR and contribute to the registry.
Yeah.
Anoop, you kind of mentioned it is your registry, it is our registry.
Sorry, Leo?
You said
Anoop, you kind of
Pachore
mentioned it is your registry. I think you should rephrase it as our registry.
Sorry, I didn't get you, Leo.
No, you mentioned when you spoke to Pachuresa, you mentioned your registry.
Yeah, I mean it was
Yeah,
Dr.
you need to
Pachore's
rephrase it to our registry.
Yeah, our registry, Indian registry. Yeah, that's right.
So thank you. We are
Thank
losing
you.
signal.
Thank you.
Thank you,
Good night,
Anoop.
good
Thank
night.
you so much. Thank you so much. It's wonderful. Wonderful talk, Anoop and Anil. I joined a little bit late during Anoop's talk, though. Thank you. Thank you.
Thank you, Anoop. Thank you. Thanks, Anoop. Thanks.
Bye-bye. you.